To find out what your obesity medicine doctor wants you to know, I reached out to Dr. Fatima Cody Stanford. Dr. Stanford is an obesity medicine specialist and associate professor of internal medicine and pediatrics of Harvard Medical School, the director of diversity of the Nutrition Obesity Research Center at Harvard, and director of equity in the endocrinology division of the very esteemed Massachusetts General Hospital. Dr. Stanford also earned an MPA, Masters of Public Administration, at the Harvard Kennedy School of Government, and an MPH and an MBA. And when Dr. Stanford completed her MPA, she was awarded the Gold Congressional Award, which is the very highest award that Congress bestows on young American civilians. Dr. Stanford is a top expert on obesity, and she challenges the notion that weight regulation can be determined by just one simple equation applied to everybody equally. And instead, she examines the impact of the environment and the role our brains and bodies play in the complex processes of weight regulation. Wow, that's a mouthful. Dr. Stanford, your long and fantastic history of hard work, fierce commitment, and contributions to the field of medicine is absolutely outstanding. Thank you so much for taking time out of your incredibly busy schedule to talk with me today.
It is such a great delight to be here with you.
I told you this before in the past, but I don't really think you really believe me. I've been a serious Dr. Fatima Cody Stanford Stan fan and follower of your work for years. And you do it looking fabulous and rocking some serious heels.
Funny, I don't have on heels right this very minute, but let me tell you, when I did have them on earlier today, they did match quite nicely.
I know they did. I have no doubt. And I wasn't even there.
Yeah.
But, I have to ask, when do you sleep?
I require less sleep than most humans. I think
yes.
My husband would concur
than us mere mortals.
I've been like that my whole life. So, people are like, oh, she needs to stop the caffeine. Caffeine makes me sleepy.
Wow.
So I think it's just how I'm wired. If you were to meet my mom, you would see a similar wiring. I'm definitely her daughter. My maternal grandmother, who's not living anymore, very much the same. So I think it's just, genetic in nature. I'll give just this, caveat when I was born, and I was born about a month early, although I went home within 3 days. My mom decided to conduct a meeting from after having delivered her first child, i.e. me, like within an hour and a half or so. And when she got on the phone, this was in the 70s when I was born, she's directing the whole staff, blah, blah, blah. And they were like, you left early yesterday. Are you feeling okay? And she's, oh yeah, I had my daughter this morning.
I just had a baby. Yeah, it's fine. It's all good.
And they were like, why are you doing this meeting? And she was like, oh, so just to give you some perspective, that was
you got it honest.
Yeah. So
you just got it honest.
She just how I'm wired.
You are definitely the daughter of goddess of.
She's amazing. I mean,
goddesses.
She knows this. She's literally like one of the best humans I think that have ever walked the earth. Of course, a lot of people think that about their mom, but you haven't met my mom. So I just am going to throw that out there to give you a perspective on where I come from, so that you understand.
Awesome. Yeah. And I do want to give props and appropriate kudos to your mom. Tell us your mom's name, Dr. Stanford.
Her name is Cynthia Wyatt Cody. So that's her name. She's adorable. I can't not say my dad though, because he'll feel left out.
We can't have that. What's your dad's name?
Raymond B. Cody. And they're adorable. They, I talk to them all of the time, every single day, even if only for a few seconds, because they know my schedule is a little, difficult to navigate. But, that's why I'm here, right? If they weren't here, I wouldn't be here. So, thanks, Mom and Dad, for dealing with the intensity that is your daughter for all of the things.
That is pretty intense. But again, the apple can't fall too far from the tree. So thank you, Mr. and Mrs. Cody, much appreciated. And, I was thinking about all of the things that you've done and, We were talking earlier and you said you can't remember a time when you didn't work at least 92 up to 105 hours a week. I know you wrote a book in 2019. It's called Facing Overweight and Obesity, a complete guide for children and adults. But you really seriously need to write a book and show us mere mortals how juggling fabulousness is done.
I'm a strong person of faith. Obviously I spend a lot of time in academics and things of that sort, but how I start my morning, how I finish my day is with God. And I really feel like we're each put here to do something unique and individual to ourselves. And when I do the work that I do it, not for recognition, although I have received a lot of awards. And those are not the things that drive me. What drives me is doing the work that I've been put here to do. And, I'm just the vehicle by which the work is achieved. And I'm thankful to have these abilities to do the work and to do it here. And Dr. Benjamin Elijah Mays, who was one of the main teachers for Dr. Martin Luther King Jr., has this major quote by which I would say I live my life. And it states the following: strive to do whatever you do so well that no person living, no person dead, or no person yet to be born could do it any better. And that's really how I navigate life. If I'm here to do the work, then I do the work. If the work really kind of comes from my gut, I think it's the work that I'm supposed to be doing. And my goal is to do this to help people. I usually tackle challenging diseases, disease processes, and it's hard work, but it's work that brings lots of fulfillment. And I'm hoping that I'm shifting the narrative.
You definitely are shifting the narrative, and you've definitely broken the mold. And it's a great segue to something I'm curious about, and I wanted our audience to hear about. And how did you come to your calling to help folks as a physician, and then particularly your specialty in addressing the American diet-related disease epidemic, meaning the type 2 diabetes and other diseases related to the disorders of overweight and obesity?
It was very early in life that I actually knew that I wanted to become a physician. Probably about 4 years old or so, I really determined that's what I wanted to do. And a lot of people that really have that kind of early determination happen to have parents that are in medicine. Neither of my parents are in medicine. My dad's an artist and illustrator. My mom was a corporate executive for Macy's for her career, and both have retired, although my dad probably has it because he still paints and things. What I really appreciated about the work of a physician, at least how I saw it as a 4-year-old, was that they seemed to help people. And I felt like I'm good at helping people, and helping people through really hard things. I didn't know what those hard things were, but those were things that I really saw. I would say I took a circuitous path specifically to obesity medicine, because when I was in medical school, or it wasn't technically a field defined in and of itself. It was around 2012 or so when you really start to see the American Board of Obesity Medicine emerge. Actually, so this was a circuitous pathway. My initial work in public health, which was over 24 years ago, was specifically looking at obesity within the Black community in Atlanta, where I was born and raised. But a lot of it was about prevention of the disease, not really treating the disease within the community. And it was only as I became, went further along in my career, recognized that this was a complex, multifactorial, relapsing, remitting chronic disease that warrants treatment that we just don't treat. We treat all of the downstream impacts of obesity. And a lot of this comes from our lack of knowledge or understanding that obesity is a disease regulated by particularly the hypothalamus. And if we can pay attention to that and recognize the chronicity of the disease, then we can actually begin to make progress, not only as it relates to obesity, by far the most prevalent chronic disease in human history, but all of the downstream impacts, which are the 200 plus other diseases that are often caused by obesity, which include, of course, things like type 2 diabetes or heart disease or 15 types of cancers, obstructive sleep apnea, joint disease, et cetera. And I was particularly intrigued and pulled to this field because of its impact on Black women. Black women are known to have the highest rates of overweight and obesity in the country. Over 80% of Black women have overweight and obesity. And as a Black woman, the group that I belong to, I particularly care about. Not that I don't care about other groups, I care about all groups, but I felt as though There needs to be someone that with a keen interest and understanding of the lived experience of the Black woman to be doing this work and to be making major shifts in the conversation around the chronic disease of obesity.
Your research, your extensive research, you've done a lot at Harvard about overweight and obesity. Can you explain what you've discovered in terms of the impact of the environment and the role our brains and bodies play in the very complex processes of weight regulation?
Yeah, I think that the way that I hopefully will explain this in such a way that you guys are able to like discern, understand, pick up, because a lot of people have not heard this. So what we have to recognize is that the most important organ that regulates our weight, regardless of our race or gender identity, socioeconomic status, et cetera, is our brain. And so the brain is getting signals from different parts of our body. It's getting signals from our adipose. Adipose is a fancy word for fat tissue. It's getting signals from our pancreas, our stomach, our small intestine, our large intestine. It's sending signals to our brain to tell us not only how much to eat, but also how much to store. There's two primary pathways, I think, to just simplify this, by which the body regulates weight. The one pathway, which we call the POMC, or pro-opiomelanocortin pathway, which tells us to eat less and store less. Many people that are lean signal very, very well down that pathway. And for patients that have obesity, they signal down an alternative pathway called the AgRP pathway, or the glutamate peptide pathway, which tells us to eat more and to store more of what we eat. And so what we've recognized—
Dr. Stanford, that's an important point I've never heard about.
Yeah.
So those of us that are lean and those of us that have overweight and or obesity, their studies have demonstrated, research demonstrated, there are two completely different pathways that we use in terms of our metabolism.
It's not just metabolism itself. It's literally, metabolism is part of the picture. It's literally telling our body even what to store, right? So
at the level of the brain?
At the level of the brain. So
Okay.
Everything, like if you're looking at medications and all of these, most of the medications, for example, to treat obesity act on part of the pathways in the brain that signal in the hypothalamic region, because that's where all of the action is taking place. And that small region of the brain is where our weight regulation happens. And you know,
that is an active, we think of it as inactive, us lay people, and those of us, many of us who are not obesity medicine specialists,
Right.
still think of fat as inactive, but it's actually very metabolically active.
Yeah, it's how the brain signals. And you don't I think a lot of us think about it, and this is why I don't really think of it as a diet related disease. I mean, I think diet is one of the small things that, relates to it, is because even without that piece of the puzzle, the brain is still going to signal, how it wants to signal. So for example, let's think of it this way, and we're going to use like kind of those big factors that we know are contributors to how the signaling occurs. The largest factor, hands down, bar none, is genetics. So if you have parents with obesity, mom, dad, there is a 50 to 85% likelihood you will have obesity, even with optimal behaviors. And by optimal behaviors, I mean eating the highest quality diet. And by highest quality, I'm not saying going and spend a lot of money on your diet. I'm talking about minimally to no processed, lean proteins, whole grains, fruits, vegetables, high levels of activity. Maybe you're engaged in high intensity interval training, et cetera, et cetera. Good quality sleep, stress management. Even with all of those things, if you are born into that milieu, that DNA milieu, we have to recognize that weight is more heritable than height. So when we see families walking around and we see individuals that all seem to have a similar body habitus, we assume that, they're all eating that poor diet. And maybe diet is part of what they're doing, but it's really the fact that they inherited that piece of the puzzle. Is also why I take care of so many patients that are 3 generations or even 4 generations. I have only a few families with 4 generations where I'm taking care of the child, the parent, or grandparents because of that high transmissibility. There's also the piece of epigenetics, which is, skipping kind of a generation. And that
Can you explain to our audience what epigenetics is?
Absolutely. So let's look, I'm going to use Holocaust survivors. This is going to be the easiest way for me to explain it. And the data we know from Holocaust survivors and their grandchildren. Epigenetics, obviously, if you went through the Holocaust, and survived the Holocaust, That was a significant stressor, trauma. I think we can all agree. What we've seen in the studies that have been published in the peer-reviewed literature is that the offspring children, meaning skipping a generation to the grandchildren, have much higher rates of obesity than those that were matched controls, meaning those that were not under Nazi rule. And so you wonder, like, well, why is that? Like, what is this epigenetic piece? The trauma experienced by the grandparents then imprinted such that it reflected even a generation beyond their children. And this is what we see with other chronic diseases. I would say the study of those that are survivors of Nazi Germany is some of the best studies that really have evaluated this in terms of chronic disease. And so hopefully that helps you understand the transmissibility, not just mom and dad to child, but grandmom and granddad to child. If that makes sense?
Absolutely. That's a beautiful analogy. That's really helpful. And I'm still stuck. I have to tell you, I'm still stuck on the fact that the data shows that DNA plays a much stronger indicator of weight more than height. I would have thought that, like all of us, we think the difference is environment, as you referred to earlier. But wow,
you referred to it. I think it's one of the things. I think that environment, we give a lot more. I mean, environment is definitely, don't get me wrong,
it's important. A piece of it, but let's just call it what it is. We all say, us lay people, folks in the public, us non-obesity medicine experts say, well, yeah, we acknowledge there's some DNA, some genetic link, but we think the difference is the environment.
Yeah, but even if
that's not the case, you're saying that's not what the data shows.
Not what the data shows. If you were to take, I'm going to use identical twins, right? Because they're really easy for us to study. Because they have basically identical DNA, but not quite, but as close as we can get. And you were to take one twin and place them in mainland China, and take another twin and place them in Zimbabwe. I'm just picking places that are nowhere near each other that, obviously the environment is very, very different. What we see year after year with those individuals is that if you bring them together, separate them at birth and bring them together 40, 50 years later, is that their body habitus is about the same. So their environment didn't seem to have a huge influence over their genetics. So when you put them back together, if they have obesity, whether they're lean, it tends to be exactly the same, despite the fact that there was no communication. They had no idea they existed in completely different environments, completely different upbringings. That DNA piece overrides all of that.
Yeah, it's pretty amazing.
It is quite amazing. And I think so that the key thing is, we're not going to say that the environment doesn't play a role. It does.
Sure.
But we just have to recognize how potent that genetic piece of the puzzle is. And so when I'm seeing children, for example, that are coming into me at 3 or 4 or 5, and they're like, gosh, what are those parents feeding them? And I'm looking at the parents and I'm recognizing that they themselves have obesity, or that there's a strong family history of obesity. And for those children, I'm sending off genetic tests to look at, the contribution of their DNA in terms of obesity. And many of them almost every single patient that I send off for this genetic test will come back with something positive. Now, it's not always something that we have any treatment specifically for, but almost all of these patients will come back with something that's a major contributor, just no therapy yet available to address that specific variant that has been shown to be a high risk for obesity, that when you subsequently test the parents, you see the exact same thing. So, we think about nature versus nurture, and yes, obviously the environment can play a role, right? If you live in an environment that doesn't have those high quality diet components we talked about, or physical activity, even for someone that has a tendency to be lean, they can develop obesity in that type of environment. But if we look at the largest contributor, hands down, bar none, it is genetics and the role it plays. If we think about the fact that in the United States, 50% of all pregnancies are unplanned, may become even more so, status post the recent SCOTUS decision, and we think about this contribution, right? You can imagine if we have 42.4% of US adults that have obesity based upon 2018 data, the most recent data we have, we're talking about almost half of the US adult population with this disease. So when we continue to see that propagate, and we continue to see that pass on to our children and our children's children and children's children's children, then we're going to unfortunately see this continue to climb until we begin to really address some of the underlying issues and actually treat the disease. Because if we treat, for example, people preconception, we do have huge benefits for the offspring. For example, and I'm just going to share this study that a lot of people may not know about it because they're not in this field. There was a prospective, which means a study looking forward, looking at children born to mothers with severe obesity. So they compared the first child born to the same mom and dad, so we have the same parents, all right? And we compared it to the second child. In between the mom having the first and second child, the mom has bariatric surgery, okay? What they found is that in the child born post the mom having bariatric surgery, this was a 25-year prospective study, so looking forward, there was a 3-fold decrease in the prevalence of severe obesity within that cohort. There was a significant improvement in lipid profile, lower weight status, higher levels of leptin, higher levels of GLP-1, all of the more favorable hormones in terms of weight status, compared to the child born before the mom had that significant intervention, which is bariatric surgery, which actually interferes with that brain-gut connection and changes the way the brain sees weight. So we know that these interventions can have huge impacts. The thing is that we just don't use them. Only 1% of individuals in the United States that meet criteria for the use of medication for the treatment of obesity actually are on medications, and only 2% of those that meet criteria for by far the most effective treatment for moderate to severe obesity, which is metabolic and bariatric surgery, have received it, which means 3% of individuals have received treatment in the form of medication and or surgery here in the US as it stands today.
Children who were born after bariatric surgery, same parents, have very, very different metabolic weight regulation numbers. That is huge.
Yeah, I think that's one of the best studies that really supports this idea of like wanting to treat the parents preconception, which means you got to treat everybody, right? 50% of all pregnancies are unplanned. That means 50% of people didn't know they were about to become a parent. And that means we have to target the population as a whole, right? We can't just say, oh, let's just target these people that are at risk. You know, these are the people that are planning to become parents, because there's another half of those individuals that you're not thinking about. And so everybody just needs to be thinking about this in a holistic population-based way to really make significant impact.
Let me go back and talk about the 2 pathways that have been documented. The data shows that are actually very well correlate with folks who have overweight and or obesity and folks who do not. Can you tell us again about those 2 pathways? And you talked about genetic testing and DNA. Let me back up. DNA and then genetic testing that has been done. It's a 2-part question. Can we talk about the 2 pathways to describe them, name the names of the pathways again? Mm-hmm. And part 2 of that question, or is it possible to, how do we test for those different pathways in folks, children, adults, either way, who we're evaluating working up for issues with weight regulation?
So I wouldn't test for the pathways. We know the pathways are there. We know that, yeah, so I wouldn't
They exist.
Yeah.
So how can you tell so the studies that were done that identified the pathways and then the differences, how were those tests done? And can they be replicated out of the clinical trial setting?
No. So that's not helpful. So it would be like inadequate use of resources. We know that this is how the signaling happens.
So everybody has the same pathway. We all have the same metabolism. Is it a question of
we don't all have the same metabolism?
We don't have the same metabolism.
No, we don't.
One gets turned on because of DNA.
So other people have different
turn
triggers.
One pathway on more than the other. Would you say that's the description?
That is definitely the case. There is not.
Then we're looking at genetic testing to figure out who tends to have the pathway, the genes where they're turned on.
We know some of that data.
Introns are turned on or off.
No, we know that data. So if we look at large scale studies that have looked at like 30, 40, 50,000 individuals, there is, if you have a TT allele pairing, you are more likely to signal with higher regulation of the POMC pathway, which is that pathway that's lean.
Okay.
If you have a CC pairing, if I have this correct, you are more likely to signal down the AgRP pathway. When we look at, for example, differences in racial ethnic individuals like myself, those that are like yourself, that are, of African descent, for example, we are more likely to have, unfortunately, the pathway that is doesn't signal as well, which means that it precludes or pretends to a higher level of obesity within those groups.
Okay, Dr. Stanford, which pathway does it not?
The AgRP pathway.
The AgRP pathway does not.
Is the one that tells you to eat less, eat more and store more.
Okay, so you're saying those with African ethnicity, the DNA tends to have more of the AgRP pathway.
Absolutely. Or more likely to signal more down.
Or signal that pathway. Yeah. And that's what was called the CC alleles, and the POMC pathway, you tend to have TT allele.
TT, well, it's a little bit more complex than that, but yeah.
So just trying to make it simple.
So I would say
we're mortals, Dr. Stanford.
Yeah, don't even think it that way. Just think that if you, unfortunately, racial and ethnic minority groups, not only those that are of African descent, also those of Hispanic origin, are more likely to have a higher likelihood of a contribution that signals more down the AgRP pathway, which leads to expression of adipose tissue, which is more excess weight.
And given the numbers, there's some Native American communities where type 2 diabetes is almost 100%.
Yeah.
Would you say that these pathways and the DNA representation, TT alleles versus CC alleles, are the same thing? Those of
we don't have their
populations.
Data. Yeah, the Native
populations.
Yeah, Native population, we don't have a lot of their data. So even when you see us doing looking at the prevalence of overweight and obesity and all of these things, and when I give a talk, I'm unable to share that data. Most of that's housed within the IHS, which is the Indian Health Service, and not necessarily shared externally with those that aren't a member of that community. But we do know that within Native communities that there are high rates of diabetes, obesity, et cetera, even though I'm unable to give you what exactly those numbers are, because they're not necessarily shared with those of us that don't belong to those communities. But what we do know is just, if we understand this disease that is obesity, right, this chronic relapsing, remitting chronic disease, is that those that tend to signal well down the POMC pathway, I would use my husband as a great example, very lean, doesn't really store adipose regardless of what he eats, he signals well down that pathway. I don't have to do a test to figure that out. I have 44 years of data to demonstrate that. Similarly, if a patient, has severe obesity by the age of 12, I can clearly demonstrate without having to do a test specifically to look at the pathways to say, he's storing more of adipose than someone else. And
so he's probably an AgRP guy.
Yeah, that's just it's pretty simple. And then the medications, right? The medications that particularly the newer generation medications, really the reason why we see the high level of efficacy, like 15 to 22% total body weight loss on average with these meds, is because their focus is those pathways, right? So they actually specifically work to stimulate or upregulate POMC within the brain. And so people will tell me when they go on these meds, it's like, oh, wait a minute, is this how you're supposed to feel? Oh, I didn't, this is just great. I didn't know what this feels like. I don't, and so then we see this major weight shift. And of course, the associated obesity related conditions also improving, but it's not because I told them to do something better. It's because I changed the way their brain sees weight. I have to sustain that, meaning I have to keep that medicine on board to change and continue to upregulate that pathway. But hopefully that helps you understand, even how, why these medications are as efficacious as they are and why there's such a big to-do over them, particularly the newer generation medications.
Definitely. And can you talk about those medications? Can you talk about, because throughout decades and decades and decades, there have been quote unquote weight loss medications, and the newer ones, the ones that have these fabulous data that shows impact. And now we know on the pathways, right? On the two pathways. Can you tell us about the category of medicines we're talking about and the generic names and or brand names?
So first of all, I don't want to discredit a lot of the more traditional meds. I do use those, and some people do well in those and not on the newer generation and vice versa. So I want to first state that, but
do you start with the old meds?
Because I've done this a lot. I kind of listen to what people was telling me and I kind of decided, but many patients in obesity medicine, particularly in our care, are on multiple meds, just like you're treating resistant hypertension.
Exactly. There are 2 or 3 meds working together.
Some may 2, some may 5, it just depends. But I'm listening to different clues to tell me what medications to use. And I would say there's a little bit of a gestalt, just from doing it a lot. I can't say, will look for this, but
there's a baseline science, but you haven't, medicine is an art and a science.
Exactly.
You've got this down to a fine art.
Yeah.
So yes, if you can tell us about the different categories of medications and ones in particular that you think impact the two pathways and the newer medicines. And if you're able to, what makes you determine, you know what, I'm going to start with this class of medicines versus
that would be the whole hour. So I would say listen to
all right,
Curbsiders podcast where I go through all of that. So just look up Curbsiders and my name, Fatima Cody Stanford, and that's like a whole hour. So I won't do that. But what I will do is start with looking at like the medications when they were first approved and how they're used and how they actually act on the brain, because almost all of them are centrally acting. So phentermine was the first drug approved by the FDA. It was approved back in 1959. Still a staple within the work that we do. Phentermine is a stimulant style medication taken first thing in the morning. It actually inhibits norepinephrine reuptake within the hypothalamus, and that actually is how it regulates weight. I would say that a lot of people have a lot of fear about phentermine as a medication because it was part of the thin combination that was withdrawn from the market back in the late 90s. Phentermine, which is PHENTERMINE, has remained on the market continuously, whereas fenfluramine, which is FENFLURAMINE, was withdrawn. It was drawn because it caused heart valvulopathy or heart valve issues. Phentermine, I think, has gotten a bad name because it played with the bad kid on the playground. The bad kid on the playground was fenfluramine, but it in and of itself has not demonstrated to have any really negative impacts on health, actually positive impacts, even improving systolic blood pressure and contributing to overall improved cardiometabolic health. So that's one drug, and that's the one that was first approved. After phentermine, we kind of took a long journey over to orlistat, which is a pancreatic lipase inhibitor, a drug that typically doesn't achieve as much weight loss because I think it really affects, or it kind of acts on the old premise that when people have obesity, they must just be eating more fat. Whereas many people that have obesity actually aren't eating more fat. They just store more fat. They aren't eating more fat. And so the side effect profile for that type of medication is loose stools that get on your clothes, if you have any gas, then you pass gas, oil all over your clothing, things of the sort, because it's seeking to block fat, but it's assuming that everyone that has obesity just eats a lot of fat, which obviously a myth. Other medications that have been approved, so phentermine and topiramate in combination. So phentermine, which we just talked about, phentermine and topiramate in combination was approved around 2012. That was synergy between the one that we talked about inhibiting the norepinephrine reuptake in the hypothalamus, and now another drug, which is used for the treatment of epilepsy, migraine headaches, and is topiramate. Topiramate stimulates gamma aminobutyric acid secretion within the brain. That's part of how it works specifically in terms of this obesity piece of the puzzle. And so it's approved in combination, on average causing about 9 to 10% total body weight loss when used in combination. Bupropion and naltrexone, bupropion being used for several different reasons: depression, smoking cessation, naltrexone, an opioid antagonist used for opioid use disorder, but also for alcohol use disorder, approved in combination under the trade name of Contrave. It causes on average about 6 to 7% total body weight loss based upon the trials with that. Subsequent to that, the first GLP-1 coming on board, liraglutide or liraglutide, depending upon who's pronouncing it, a daily injection approved for the treatment of obesity starting at the age of 12. And then, of course, our second generation GLP-1 from that same company called Wegovy or semaglutide, depending upon who's pronouncing it, with a treatment dose of up to 2.4 milligrams or 2.4 milligrams once weekly injection, on average leading to about 15 to 16% total body weight loss with continued use. And then what will be the new golden child on the block, which is a combination of a GLP-1 agonist, which were like the liraglutide or semaglutide. Now we have tirzepatide, which is Eli Lilly's new drug. It's a combination of a GLP-1 agonist, glucagon-like peptide 1 agonist, along with a GIP, which is a gastric inhibitory peptide, and the combination of those on average producing in these studies by Dr. Anya Yastreboff at Yale, 21% total body weight loss at max dose.
Everybody's really tripping out about this last one.
Yeah.
Everybody's so excited about it.
Yeah. So the funny thing is for me, I'm excited and I am happy to see the new generation of drugs, but I think a lot of our, like, on average, really lackluster, results from the earlier generations that people just didn't know how to use them. I've had patients lose 50% of their total body weight loss with phentermine and topiramate. I told you average is 10%, but average is average, meaning they're going to be high responders and low responders. And there are some people that don't respond to the newer classes or have very minimal response, and they respond better to some of the more traditional drugs. I think right now we're not in a position of really having that precision medicine. I can't, like cancer drugs, I don't just give you the cancer drug, right? I give you a cancer drug that's targeted to your specific type of cancer on your whatever particular receptor. And
That's
similarly,
right.
I think with obesity, I find that, for example, I may try a patient on med 1, 2, 3, 4, 5, 6, a combination of 2, 4, 7, or whatever. And then I get to medicine 8 and it was metformin and they lose 60 pounds. Like, if I'd known that, I would have maybe started them on metformin earlier, but metformin is not a drug that we assume will cause much weight loss. It's pretty lackluster on average, but for the right person, 60 pounds. You know, some of it is like just that kind of art, but sometimes I don't still know. And it takes us that trial and error to find out, you know, oh my goodness, this is the medication they responded to. Who knew it was metformin, the $2 medicine they can get at CVS by just walking in, probably not even getting a script, right?
Yeah.
But we don't know that, right? Like we don't know that. And so, you know, I might go to the big gun, right? I might go to semaglutide, which is available. Of course, tirzepatide has not yet been approved for the treatment of obesity, only for the treatment of diabetes. And, you know, put them on that and they lose like 2%. And you're like, really? That's supposed to be like the best. And I've had, a few patients that have, maybe a little bit more than a few, that have fallen into that domain for semaglutide. And then I put them back on their more traditional meds, meaning those ones that were approved, before, and then their body reverts back into a losing state. So it's, a lot of it's like, we don't know that piece, right? I'm not able to go in and say, ooh, we need to really upregulate that GABA secretion, right? That'd be great. And I'm like, ooh, I know the drug for that, right? But we don't know that at this level. And I think the only field that really has that level of precision is oncology, right? Like even in hypertension or diabetes, we're like, oh, well, this is a diabetes drug. Let's just use it. That's important to know.
You talked about the cost of these medicines, and what's so exciting about metformin is that it's so cheap. I can't even imagine what the new GLP-1 combo we just talked about that just came out that, demonstrated 20% of, body weight loss. I can't even imagine what the cost of that's going to be. I'm concerned about the cost of these medicines because they haven't been approved off-label often for weight loss. They're approved for diabetes often.
Well, no. So semaglutide is approved for obesity. So everything's approved for obesity with an exception of the most recent drug, Eli Lilly's drug.
As a result, even when they've been approved, my experience is commercial insurance companies won't cover it for the indication of obesity or for weight loss. If there is no documentation in their data, in their files of an ICD-10 diagnosis code for diabetes, type 2 diabetes of some form, they're not going to cover it. And so,
yeah, it's so frustrating. So I've written about this quite a bit. We get excited, unfortunately, when our patients have diabetes, which is a really horrible thing to hear doctors say. But when you know that you can get the medicine covered if they have diabetes, but not with obesity by itself, you see, oh, wait a minute, we have diabetes. Look, that A1C is 6.6. Oh, wow, that's great. Okay, now I can get the medicine. That is an absolutely horrible thing to say. But I recognize that it's not just us, meaning us here in the US that are practicing physicians. I just published an article about 2 or 3 weeks ago with one of my colleagues from Germany that also gets excited when her patients get diabetes because now she can get the medicines covered. So it seems to be something that's pervasive, in the community at large, but it goes to our biases
exactly.
I'm going to say and/or lack of knowledge about obesity as a chronic disease.
Exactly.
And if
in the medical system. So
right.
If it were the gold standard, the insurance companies would cover it.
They would. I mean, there's some, I would say the major policy holdup is that Medicare, based upon some of the older drugs, the amphetamines that really predate phentermine, which was, approved for obesity, Medicare Part D has excluded the coverage of anti-obesity medications altogether.
And for our audience, they may not know this, but what happens with Medicare, every other commercial and Medicaid, all the other insurances follow suit.
Yeah. So that's the issue. So if Medicare, this morning I had the privilege of talking to Secretary of Health and Human Services, Dr. Becerra, and I said, look, we've dropped the ball. We've been trying to introduced the Treat and Reduce Obesity Act in both the House and Senate since 2013 to just get medications covered. And believe it or not, right now, if you're under Medicare and you want to work with a dietitian on maybe your diet, want to improve upon it, you do not get that visit covered if you just have obesity. But if you do have diabetes, guess what?
It's covered.
It's covered for you, right? So you have to get diabetes to work with a dietitian. Isn't that great? Thanks, the United States. So it's backwards, right? Like I would want to prevent the diabetes.
Right. Prevention, an ounce of prevention is worth more than 10 pounds of cure.
Right.
Exactly.
So if we're talking about that and we can't cover it, and we know Medicare sets the standard for private insurers, for Medicaid, then we're in a really bad situation for a disease that affects 110 million adults, right? So that's problematic. And so let's look at the cost. You asked about the cost on average, semaglutide, $1,600 a month out of pocket costs. So patient, I'll just pay for it. I'm like, okay, if you'd like to, but it's cost prohibitive unless maybe you're Elon Musk.
For many of us, it's cost prohibitive.
Yeah. Right. Yeah. So if you're Elon Musk or, Bill Gates or someone like that, then maybe this $1,600 a month will feel like, I don't know, 1 cent. I don't know what it feels like to have that much money. But for most of us, that is a sizable amount of money to be paying every month.
That's not even feasible. It's not feasible for many of us.
It isn't. You're right. So it's one of those things that we need the coverage. And if you have diabetes, it gets covered. But if you have obesity, not covered on average. And it's really disturbing. And I can tell you that when I'm seeing patients, I'm often not making decisions about what I want to do with them. I immediately look at the left side of my Epic screen and see what their insurance coverage is to know what I have the ability to do with them.
Exactly.
And that's how I have to practice, because I can't just say, hey, yeah, just, I'm going to write this script for you. Just go down to the pharmacy, pick that up. It'll be, $1,650. No, that's not a one-time cost. That's going to be
per month, every single month.
So you just set aside, for the year, get 20,000.
5 figures
for that one medicine. Yeah.
Yeah.
Just do that and you're
fine. Good.
Yeah.
So Dr. Stanford, I'm pretty sure I'm going to get in trouble with you for asking this, because we talked about so much and you're so incredibly brilliant. And I know it's like trying to herd cats, but can you tell us one thing? What does your obesity medicine doctor want you to know? If you just had to synthesize it, right? You can't just pick one, top 3.
I'll do the one. I feel like I'm feeling confident. The one thing is that obesity is a chronic, relapsing, remitting disease. That is not your fault. If you know that one thing, that takes us a long way in terms of addressing the disease. There's a lot more that goes to that, as you've heard during this talk today, this lovely conversation, but that's the key thing I would want to get across.
Brilliant. I cannot thank you enough, Dr. Stanford, for joining us and sharing your outstanding, incredible insights. It's going to take me a while to marinate on this and synthesize and try to, I pride myself on making difficult concepts simple and breaking them down. And I've been given, you've been very helpful with making hard concepts, difficult concepts simple. And I'm going to try to document that and, write it down for folks to refer to.
Yeah, the hardest thing I think is probably the pathway. So this is the way I would explain it. And this is how I kind of explain it to patients when I'm thinking it through. So imagine you are on a toll road, right? And you have to go through, you're on the expressway, you have to get to the toll. You get in that lane, you just breeze right through. You're like, yes, I barely noticed I went through a toll. This is great. I love this lane. But then
easy pass. Yeah, I gotta love it.
That's right. Those are the people that are signaling down that POMC pathway. Just kind of breeze right through. You're like, look at them.
Life is good.
It's great. It's great.
Yeah.
And then you have these people that get trapped in this thing. You're like, oh my God, how did I get in this lane over here? And it's not fair because you're like, you see all these people over there and you couldn't have dashed way over there.
You can't back up.
You can't do anything.
Back up. That's illegal to back up to get over to the other lane.
Exactly. So then you're like, finally I'll make it through. Eventually you make it through, but these other people that are over there, like the breezy people, they're like at work. They're wherever they need to be.
Right.
It's not something you chose. It's not like you said, oh, I need to get, but it's how your brain decided to signal. So think of that POMC pathways that, just kind of My husband, I like to use him just because he's been with me for 28 years, but he signals very nicely down that pathway. He doesn't have to work at it. He doesn't have to think actively, oh, I'm going to eat X number of calories, I'm going to do. He doesn't have to do any of those things. He can do it, it's just how he signals. Great. My patients don't do that. Everything is an effort. Walking past a pizza shop, they feel like they gained 20 pounds. I mean, it's a little bit overwhelming, but there's probably not too far from the truth. They eat like a quarter of the pizza and they store all of it. My husband, he can eat the whole slice and you see none of it. You're like, wait a minute, did he ever eat pizza in his life? It's not a fair card that he was.
Life isn't fair,
right?
Life isn't fair.
But it is what it is. And so if we recognize that, take the blame away from the patient, say, yep, we have this disease, but let me help you address it. It just changes the entire narrative and conversation, and it makes people feel appreciated and loved. And I know we don't use the word love, but I'm using that today for some reason when we talk about obesity, but I think that's what makes the work that I do with my patients special. And I've had students recently get on and they're like, are you all, do you, it's like you kind of like are like their family members, like every visit. And all of my patients are very different. I will tell you that. I have like a microcosm of the world in my patient population. But I have to see what can I do or say, or how do I create a dynamic? Because weight is probably the most challenging thing to discuss in the clinical setting. Not that other things aren't challenging, cancer, all these things, but at least people recognize it's a disease and they don't usually put the blame on themselves. With weight and obesity, that's what I'm having to undo the whole visit, every visit. And so when I change the narrative and make them part of the family, my family of their care team, but particularly just me, is that I want to be treated exactly in the way that I'm treating my patients. Like if I were seated in their seat, how would I want my doctor to address it? And if I find that I'm deviating from that at all, I do a check on myself, because that means I'm not doing a good job. That's how I'll conclude.
You've also done a TED Talk. And I think that's a great place to send folks to find out more about your work and about the pandemic and the myths around obesity. And that TED Talk, I believe, is entitled The 3 Pandemics.
Right,
So we'll
exactly.
send folks there. And also, can you tell us where we can find you on LinkedIn, IG, and Twitter?
Yeah, feel free to, link in Twitter, find me on Twitter or Instagram at ask Dr. Dr. Fatima, Fatima. And, I try to keep things posted there. I would say I need a human, probably several humans to do the volume of what I do. I think you can go through and get some snippets of information that even won't have, we wouldn't have covered, today. And, so I think you'll find it, there are obviously very different fills of those different platforms for those. I would say LinkedIn is where I shine the most. But, I do spend some time on Twitter and on IG. And, my goal is this information is not specific to one cohort, right? Like this affects all of us. And I think that we can all think about our family or our friends or individuals that can benefit from this information. And so my goal is to make sure whoever wants to hear or listen can get access to that. The other thing I would say, if you have nothing else, if you do nothing else, is to watch my Radcliffe obesity talk that I gave back in 2018. I don't talk about the newer drugs per se, but it really shows you, I go into the deep dive of those pathways. You get to see them in real life. You get to see all of these things. And this was a talk for the public. I still talk at, a certain level, but it's the only way I can really explain like a pathway is to show the pathway. But I think you'll find it very educational. I do require all of my patients watch that before their initial visit, because if not, they go into a visit with an understanding about this disease that's very different from what I'm thinking. And if they have that and come informed with that to
meaning beliefs of myths, as opposed to
they come
the
in
knowledge base from the data that you have.
Exactly. I'm not just presenting my own data in the talk. Actually, I don't know if I present any of my own personal data in that talk, but I do present different research that supports what we do know about this disease and the complexity of the disease and how it affects different populations, et cetera. And so I think it's important to have that information and be informed so that individuals, when they step in the first day, if they're stepping in person or doing a telemedicine visit, they recognize not to go down these myriad of pathways that will lead us to a dead end. Right. So, yeah.
And that is the Harvard University Radcliffe talk that can be found on YouTube. I've actually seen it. It's outstanding.
Yeah.
Dr. Fatima Cody Stanford, MD, MPH, MPA, MBA. Oh my gosh, outstanding. I can't thank you enough. Thank you so much for joining us.
Well, thanks for having me. It's been an absolute delight. And I hope that you guys are listening. You're not like, oh my God, I'm overwhelmed. Hopefully you feel informed and feel empowered. You know, if you yourself have struggled with this disease or a family friend, et cetera, to change the narrative and to get the treatment that you deserve like any other disease process.
Thank you for showing us how and helping us to change the narrative. And this is basic life information, basic life skills, basic life knowledge that now we know, now we're empowered with. Thank you, thank you, thank you.
Absolutely. It's been a delight.